This presentation is on melatonin, brought to you by
Nayeli Ibarra,
Andrea Colon,
Jeanette Gardner,
QFAM, Nucleus Wu.
Melatonin is an indole secreted by the pineal gland and is best known for its association in regulating circadian rhythm. This hormone has multiple physiological functions such as modulation of the neuroendocrine reproductive axis, metabolism of lipids and carbohydrates, rhythm of body temperature, sleep and wake rhythm, oxidative status, and inhibits cell proliferation and invasiveness of certain cancer types. Low dose of melatonin typically starts at 0.3 milligrams per day. This dose is typically used to regulate sleep and for jet lag. High dose is considered 20 milligrams per day and is used in cancer management. Some practitioners recommend starting at a low dose of 0.3 milligrams and increasing the dose over 1 to 4 weeks to 20 milligrams to minimize side effects, which will be talked about later. It has been found that 20 to 30 milligrams nightly have helped to reduce chemotherapy side effects. These include thrombocytopenia, neurotoxicity, and cardiotoxicity. Melatonin plays several important roles in cancer therapies. The anti-carcinogenic effects of melatonin relies on its antioxidant, immune-stimulating, hematopoiesis, and apoptotic properties. Melatonin protects against free radicals. Free radicals are involved in many disease states as they alter lipid, protein, and DNA formation via oxidative stress. When DNA is altered, it can undergo mutation and progress to cancer. Melatonin has been shown to limit the cellular uptake of linoleic acid. After its entrance into the cell, linoleic acid is converted to 13-HODE, which causes a series of intracellular events that accumulate in cancer cell proliferation. The anti-estrogenic action of melatonin could also enhance the ability of the indole to limit the proliferation of hormone-sensitive breast cancer. I3C may act as a chemopreventative agent for breast cancer through its estrogen receptor modulating effect or upregulation of apoptotic enzyme activities. Melatonin can be easily found over the counter for consumer purchase and does not require a prescription. Quality of product should always be considered when buying anything over the counter. This presentation is a level 4 evidence for the use of melatonin in cancer therapies. This is based on case series, case control studies, and historical controlled studies. Several studies report no contraindications to melatonin use short-term, but no studies have been conducted with long-term use. So are there certain cancer types that seem to respond better to melatonin therapy, and what are contraindications to its use? Melatonin has been shown to be effective in treating several types of cancer, including breast, thyroid, prostate, and colon cancer. And melatonin enhances DNA repair in breast cancer and colon cancer by affecting genes involved in DNA damage. Melatonin has been shown to inhibit proliferation and migration of thyroid cancer cell lines in vitro studies. Sustains proliferative signaling, cancer development and progression is associated with the ability of sustained proliferation. It inhibits nuclear factor kappa B to enhance anti-cancer effect of berberine against lung cancer. Inhibition of nuclear factor kappa B by melatonin prevents motility and invasiveness in HepG2 liver cancer cells. Anti-growth signaling. Cancer evades anti-growth signals to proliferate. Melatonin induces phosphorylation of p53 at SIR15. This causes proliferation inhibition and prevents DNA damage accumulation. Resistance to apoptosis. Cancer cells can evade apoptosis. Melatonin induces apoptosis in hepatoma, urine, gastric cancer, and prostate cancer. Caution should be used in pregnant and nursing women, as little studies have been done showing any possible side effects. Why would we recommend melatonin use as cancer therapy? Melatonin has been shown to be effective in treating cancer without side effects in short-term use. Melatonin has been shown to increase the effectiveness of chemotherapy agents, including tamoxifen. In certain studies, tamoxifen was not effective when used as a solo treatment for the management of breast cancer. Adding melatonin in adjunctively was, however, effective in shrinking tumor size. Melatonin can be an inexpensive adjunct to cancer therapy. Prices typically range from $5 to $20 for a bottle, depending on the strength, quantity, and quality and purity of the substance. High potencies typically cost more money. So why wouldn't we recommend melatonin? Well, melatonin use has been controversial for the treatment of lymphoma and leukemia, as melatonin typically acts as an immune stimulant and can alter B cells. Caution should be used because of this. Nanomolar concentrations of melatonin are not sensitive to androgen-independent prostate cancer cells or glioma cells. People with dementia or other mood disorders and some autoimmune conditions may react negatively to melatonin. Possible reactions include headache, nausea, dizziness, nightmares, or drowsiness. Melatonin also interacts with CYP1A2 substrates. That concludes our webinar. This webinar is for educational purposes only and should not be used to diagnose, treat, cure, or prevent any type of disease, including cancer. These statements have not been evaluated by the Food and Drug Administration. Thank you kindly for listening.